a lot of what, and you guys are all at the undergraduate level, is that right?
Mostly undergrad, but there are some postgrads and there are some high schools.
Okay, got it. And there's, I assume, an interest in medicine as a whole, or anything, any particular specialties?
Feel free to unmute or put in the chat if y'all have any.
Anesthesiology.
Okay. So, I think, oh, I see urology here. Okay, good. So, I kind of wanted to spend some time, I apologize, I don't have a slideshow, but I want to spend some time talking about sort of my path to medicine. I think what a lot of us, what a lot of folks go through, and then maybe spend a little bit of time looking at what admissions committees look at, things like that, that's actually going to help you guys at the, at the level of where you are. And so, with that, I'll kind of start with what my role is now. I'm in practice with Gulf Coast Vascular Partners. It's a new group of 5 vascular surgeons, and we're rapidly growing. And we are all faculty now. I was at McGovern before, but now I'm with the University of Houston School of Medicine, which is a new School of Medicine locally. We're just in our inaugural, actually second-year class now. And so those students are starting to get some exposure into the clinical activities, as part of the 3rd and 4th year rotations. And one of our, actually the multitude of sites we go to will be involved. We're actually going to be intimately involved with medical students and surgical resident education. So, I'll tell you, I started. I'm from here. I'm from Huntsville, actually, small town just north of here. I'm sure you guys are familiar with. I grew up in Huntsville, and then did high school and undergrad here in Houston at the University of Houston, and then medical school in Arizona, and then back here for residency at the University of Texas in Houston, and then a fellowship in vascular surgery in Greenville, South Carolina, at the University of South Carolina, and back in practice now. So I think my path to medicine is actually pretty unorthodox. I'll tell you that. Growing up, I was never really interested in medicine. To be perfectly honest, I didn't know what I wanted to do. At the time, I don't even think it was anything academic, to be honest. I wanted to be a basketball player and all this other fantasizing stuff, but none of that was true. So I eventually just went to undergrad at the University of Houston, and it took a while to really decide what I wanted to do with my career. And probably until the 3rd or 4th year, it was, I got my degree in applied mathematics and economics. There was nothing in medicine. And then I did some work at an orthopedics implant design company. We were helping design implants and mathematical modeling and things like that. We saw some, at least I saw some surgeons do basically dynamic testing on these orthopedic implants. And the testing was, they'd come in and they'd actually do the surgery on a cadaveric knee. And I thought that was the coolest thing. And, from that, I was like, well, the surgery thing's kind of neat. And that's what, sort of sparked the interest, And I don't know how much you guys are familiar with osteopathic medical schools. I'm a DO. And I didn't have very many prerequisites, as you guys can imagine. I was an applied mathematics major. So, but I was fortunate to get into the DO school, and, I capitalized on that opportunity. And so I was in Arizona, and what you guys will also face is that, there's a lot of competition when you go to medical school. Especially for those of us who are unorthodox applicants, or whatever test taking issues, whatever they may be, the DO is actually a really good option. I can say that we can talk a little bit more about the nuances of that, particularly as they relate to specialties and subspecialties. But I think that's a good option. And so I decided to go to medical school, and then came back to Houston for residency. Let's see, okay, what's the deal? So DOs, so there's two accrediting committees here in the United States for medical licensing. One is a DO and one is an MD. Okay, so an MD is Doctor of Medicine, DO is a Doctor of Osteopathic Medicine. Traditionally, when I say traditionally, I mean years ago from the conception of the Doctor of Osteopathic Medicine, it dealt with a lot of primary care, a lot of holistic medicine, a lot of manipulative medicine. When I say manipulative, I mean a lot of aligning, kind of like some of the things you think of as a chiropractor, but perhaps a little more. And it was all part of the medical education that has sort of evolved over decades, and it's now you don't really find very many people who are DOs who are doing that type of holistic medicine. It's still part of the training, and I think it's definitely a lot part of my training. But you can imagine that as a vascular surgeon, I'm not doing much manipulations, but it's there, and it's. I think that it offers a little bit of a different angle into medicine. There's a lot of holistic sort of whole body treatment stuff as opposed to single specialty care, and it's really a different dimension. And for those of you who are interested in that, I mean, I think it's definitely an option. There are no limits in practice. I'll tell you, there's very few people who even know that I'm a DO, unless you like take a look at my business card or my jacket, or my white coat. I mean, it's just not, that's just not something that comes up. But it's, but I will tell you that that it's definitely a part of the training that I use. I mean, I genuinely feel that part of the DO training is something that I take with me when I see patients. And again, not so much part of the ins and outs of the manipulative medicine, which is called OMM, osteopathic manipulative medicine. We don't do much of that, but as far as the holistic approach to medicine, absolutely. And so that in a nutshell is a DO. Now, so going to medical school, it was always, I kind of went to medical school to be a surgeon. And so, that kind of lends itself to the opportunity to really develop an understanding of what I wanted to do and what it takes to ultimately get into that specialty. That's something that I think that, I guess I can't stress enough, is that for those of you who are really interested in a specific specialty, I think it really pays. If you think about it, you have 4 years of your medical school education to determine what you want to do for the rest of your life. I'll be honest with you, that's not enough. It wasn't enough for me. We see a lot of folks who come through, and especially when I was at the University of Texas, or even when I was in training, you'll have a medical student who's in their second year that'll come and say, I want to be a pediatric cardiac surgeon, for example. And my first question is, how? Not how are you going to do it, but how do you know? But I think that's something that's something to at least keep in mind, because the admissions is challenging. It's hard to get into certain, it's hard to matriculate into certain programs, certain specialties, and everything you can do to really improve your application, whether it be publications or presentations and the like, all will serve you, and you'll have benefit in your ultimate goal of reaching that target. And so the fact that I was interested in a surgical specialty from the onset, I think, it was fairly clear in my mind. So it was just a matter of what specialty I wanted to do. Initially, it was orthopedics, because that's all I knew. And then eventually you quickly realize, as you go through training, and as you go through rotations, et cetera, you realize kind of what your niche is, what you like. And so I spent a lot of my, the summer between my first and second year, I spent doing research, and trying to publish, and write some case reports and network and see what I could do about matching the general surgery residency. And I was fortunate to match the University of Texas here, Houston, and I spent 5 years there as a general surgery resident, and then ultimately went to the University of South Carolina for vascular surgery fellowship. And that was, that was just, I wanted to go to the best program I could, and that's where I ended up. A lot of what happens at the level of the admissions process is kind of there's a lot that happens, and folks like to admit someone who is a known entity, right? I mean, I remember being at admission committee meetings, and there's literally hundreds of applicants. You can imagine how hard it is to try to determine or find a good applicant, right? Everybody's got great numbers. Everybody has, 99 percentile on their USMLEs or their MCAS or whatnot. And I mean, it makes it very challenging to differentiate one candidate from another. And I think that's where the little things that go over and beyond, like, reaching out to program directors or because ultimately as an attending or as a trainee, in that relationship of an attending and a trainee, we want somebody who's willing to learn, right? I mean, you basically just want a sponge. You want a dry sponge who's going to take in everything, and someone you can teach the art of medicine to, and the science as well, and they're going to take great care of patients, and that's ultimately what we want. So I mean, and again, of all the people that are there, there's nothing saying that one person is better than the next, but if you just make your efforts to stand out, whether it be with applications or interviews or personal contacts or whatever they are, I think it definitely goes a little further. I'm looking at this chat screen here. Give me a second. Being a vascular surgeon, how do you keep up with the OM technique? Yeah, so I think I don't. I do almost none. I'll do some OMT on my wife maybe, but like I don't do much at all. So, but I think it's more of the holistic part. It's part of your training. You do a lot of that, and that's something that I think. I may not even realize I'm doing it at times, but it's just part of your training, the holistic medicine part, and that part is more so than the actual manipulative medicine. And I'll get to that, to your question, Rebecca. And so when you look at applying to medical schools or applying to residencies, there is very little that stands out from one applicant to another. And that's not in any way to take away from, and sometimes it's almost like, when you're looking through these applications, it almost feels like there's some injustice because, you have to pick one person, and you have to pick X amount of people. And we had hundreds of applicants for 6 or 7 surgery spots, right? I mean, it's not, I mean, that there's nothing saying that the one person you pick is going to be better than the 693 that you didn't. And so that's a challenge, right? And so everything that you can do as an applicant to differentiate yourself is definitely big. I'm seeing some questions about the MDDO thing. I figured that you guys would have a lot on that. I think I'm happy to talk about that. So Rebecca, the advice between MD and DO schooling to become a critical care surgeon. So good question. So critical care surgery is general surgery plus a critical care fellowship, right? So you need to get general surgery training. General surgery training is a 5-year general surgery residency program, and then critical care is, depending on if you're critical care or acute care. Critical care is 1 year, acute care is 2 years, and acute care includes critical care. So that's, you're dedicating 6 or 7 years after medical school to that training. For someone between MD and DO school, I'll tell you this, that when you apply to medical school, you just want to get into the best medical school that you can. Let me just leave it at that. And that's not to say, I mean, there are some DO schools that are, in my opinion, better than some medical schools. And, the contra is also definitely true, right? Which brings me to Nandan's questions. But ultimately, it's kind of like medical school is just learning language. I got to tell you, after I go through this whole thing, you're just learning a language. You're learning how to communicate. I don't think you're quite learning what to communicate. You're learning how to communicate, right? You're learning a language. I mean, my young kids string together all these words that make no sense, but they're words and they're in language, right? And so I think that that's what a lot of medical school is. If you go to a DO school or an MD school, what you're learning is the language, and I think that's something that you really have to embrace and understand the nuances of those differences, um, because really hanging your hat on MD versus DO in terms of training and not, I think that's probably a little short-sighted. Now, that's for the individual candidate, for the applicant, for the person. But the stigma issue is a separate issue, and that's a good question you asked, Nandan, is that, is that you have some sort of stigma? I mean, I'll tell you this. So there's, I remember there was a guy that was trained at some, I forget, he was actually at a very good school out of, somewhere in Africa. And, we even talked about his curriculum. It was a great school, right? So then there were a bunch of, foreign medical graduates who actually kind of was like, oh yeah, that's not a really good school, okay? And then there's a DO who says that, oh, this person is trained at this foreign medical graduate, and I'm not really sure if that's all that great. And then there's someone who's at a state school that's saying, yeah, I don't know about these DOs. And then there's someone at, some big academic university house, or I don't know, the Ivy Leaguers that are like, oh, well, we're the cream of cream. And then, I personally believe that you're going to have some degree of stigma for some reason along your path anyways. That's just going to happen. And regardless of what that stigma is. And, I don't know that I've ever experienced that, but I will also say that I wasn't quite looking for it. I mean, that being said, there are patients who come up to me and call me Dr. Doe, because they think that's my name. And so that, I mean, these things happen, right? But it's never really crossed my mind. I'll tell you that. Now there is some stigma in getting into competitive residency. I think that's something to remember. Once you're in, then I think then it's all the same, right? I mean, now DOs also have their own residencies. That's all changing. Everything's becoming one ACGME, American College of Graduate Medical Education training program. So you may not see much of that. And I wish I could tell you guys more. I'm not that up to date on the latest in that. I'm a little bit removed from that, but we can find, it's not hard to find out. But I don't necessarily, I think it's only going to get easier, put it that way. I mean, there were times when I could say that, oh yeah, someone didn't think I was enough because I was a DO and whatever. I mean, it's kind of like Tom Brady being the 199th pick, right? I mean, it doesn't mean much. So I think ultimately what you decide to do and where you go, I have never really seen the DO thing as ever if anything, I use it as a chip on my shoulder, right? I don't want anybody to say, oh, such and such because he's a DO, right? And that's kind of, honestly, that's taken me pretty far. And at least personally, I've never felt that way. But yes, there are some older physicians. I mean, that's, they're, I mean, hell, the training programs are the same now, right? So, I mean, if all the training programs are the same by the American College of Graduate Medical Education, it's hard to believe that, and I don't know how many more of those older physicians will be left when you're in the meat of your practice. Rebecca, let's see, I'm thinking of doing research into a nursing relationship in the hospital setting. Let's see, the question is, I'm thinking of doing research into the nurse-physician relationship in the hospital setting and how it can be improved so that care to the patient is ultimately improved. How did you get involved with publications in medical journals? That's a great question. So I think that, so a lot of what you get involved in is a lot of the opportunity that you have. So it's amazing how I would just email folks and see if they had a research project or there's something I could perhaps get interested in. And so I use auto lights. And so as soon as I was involved and, that kind of, became my interest, right? I mean, I'll tell you, like some of my early case reports and things like that in medical school were like, some rare small bowel tumors, and there was like a case study of maybe 3 cases or something like that when I was a medical student. Like, I'll tell you, I have very little exposure and even less interest in small bowel tumors now. But at the time, I mean, that was that was something that was definitely there. It was an opportunity for me to learn. And at the time, I really did think that I was going to do general surgery. I wasn't quite interested in vascular surgery, and I was a medical student. And so, when I got involved, a lot of it was just getting what was available more so than seeking what my interest is. And I'm not in any way saying that's what you should do. All I'm saying is that that's easier to do. I mean, it's difficult, to your question, Rebecca, to elucidate something that you're interested in and then find a research project accordingly. It's just hard. I'm not saying it's not out there. I'm not saying it's not doable. I think that your work is just a little bit more cut out for you because you're looking for something specific. Versus emailing folks and just saying, hey, do you have a research project I can work on, right? And it's important to your career to get involved in these things, but at the same time, I don't want in any way diminish your interest in something specific, right? Because there's nothing better than your specific interest because that comes with a passion. And so and a lot of these, for example, your question specifically about nurse physician relationships and patient care and things. I mean, these are questions of utmost importance. And so as a decision to do research in that's fantastic. Getting to that end may be a little challenging. And so I would just start off with taking what you can get. You learn the process of how to collect data. There's so many how to put papers together, interactions with attendings and other research people. I mean, there's a lot of other things that you learn, which will ultimately be translated into your desired interest. And so, I guess something is better than nothing. And so just get started, and then you'll see how doors just kind of open up when you get aggressive about something. Let's see. So, how important are publications during undergraduate career, and how to obtain them when you practically have no experience? And that's exactly that. It's just as an undergrad, I did not. I did nothing in the realm of medicine. So I wish I could answer that question. I think that a lot of it is just exposure, right? Because ultimately, yes, you want to be a competitive applicant and you want to get publications, et cetera. But this, I think sometimes lost in all of this is that this is your life and your career. And so you just want to make the time to do everything you can to make sure that you are truly interested in medicine. That's I cannot say that more than, I mean, there are many, many, many people who are just miserable in medicine. And so, more than I would use my undergraduate years while I'm contemplating applying to medical school to really make sure that this is what I want to do, right? I mean, you're looking at I spent 11 years after undergraduate training to be in a specialty, and so and you're trained in such a thing that it's very hard to make a lateral transfer, right? It's not like you're an accountant and then you went into finance. I mean, not to say they're the same, but it's a little bit easier of a transition, at least in my mind, rather than spending, 11 years down this hole and all of a sudden saying, you know what, I really don't want to do this. There's a lot of backtracking and re-angling and going forward, and all of that takes a lot of bandwidth. And also it happens at an age when you're older, right? You're no longer in your 20s. And so that's something that I would really advise as an undergraduate. And the best way to do that is just shadow and, spend time in hospitals, this kind of forum maybe, and things like that. It's going to make it kind of difficult in COVID, but that's the publication part as an undergrad. I didn't really pay attention too much. And I'm not in any way saying that that's a bad thing, but it's always nice. I mean, if you get your name on a case report or some publication or something like that, it definitely makes you stand out at least a little bit compared to the number of applicants that are applying to medical school. Can shadowing make you more competitive in medical school? Yes, because shadowing will give you the opportunity to get a letter of recommendation. And a lot of what we do, right? You can imagine when you're on the admissions committee and you're looking at a number of applicants. I mean, it's we want your letters of recommendation to reflect that someone else also vouches for your interest in this field of work, and that someone else is presumably has a really good idea of who you are, and also idea of their work, and so I think you really have that going for you when you have a letter from them, and I think that's where shadowing helps. It helps in two ways. Number one, it helps you understand what you want to do, and number two, it helps you get letters. Those are the two things I would say about shadowing. But I urge you to not get so hung up on the shadowing part of that specialty, right? A lot of folks do that, and I think that and sometimes it kind of closes your mind to one specialty. If you just keep a really, really open mind as you go through, you'll have a not that so for example, with me, I was so much interested in orthopedics, and I hung out with a few surgeons, and they wrote me letters and all this good stuff, and I walked in thinking, yeah, maybe this is probably what I'm going to do, and I do things that are very different than that. So and I was also guilty of that, as in thinking that, hey, this is what I want to do, but the truth is that you're really only seeing the tip of the iceberg in this. And so shadowing will make you competitive, yes, but as long as it doesn't sort of put blinders on you. What are some things that you would recommend with step one being pass or fail next year? God, I wish I had an idea. I have no idea. The only thing I can say is that I'm glad that it's not that I'm done with training, because the reason I say that is because when I was I would not be able to match into a competitive general surgery residency program at a big academic place if it was a pass fail, right? Because what made me stand out was my scores, and it makes it a little more challenging. Now, that being said, it doesn't take away from the fact that you build your context, you build your case, you have your letters of recommendation, all these other things are there, but it's one more opportunity to stand out. But for whatever reason, they've sort of transitioned to the pass fail. I suppose step two is a way to stand out. You'll have to take step two a little earlier. A lot of people take it their fourth year after they match, after applications are in. I think that's all I can really say, but I wish I could tell you more. What is your favorite and least favorite part of your specialty? So vascular surgery has the highest mortality rate of all surgical specialties. We just take care of really, really sick patients, aneurysms, stenoses of all these arteries, stroke patients. We take care of a lot of complex pathology, and that that lends. I mean, it's nice. It's very rewarding because you can help folks a lot. But the least favorite part is that you also have your fair share of folks who don't do well, and the folks who you may not have the outcome that you really wanted to, and that's a struggle. It's not it's something that you get used to, but it doesn't change the fact that you have that you may have a negative outcome that you definitely, you take that home with you, and you never get used to that feeling, and that's I suppose that's the least favorite part, but it's also the best part because guess what? I mean, when the music stops, you're there, and you're there to help with anything else that you can, and take care of these complex stuff. Um, but that's the nature of the beast. Right? I kind of knew that walking in. So, but it sucks. It sucks when it happens. How important is it to do detailed medicine research versus basic natural science or biology research? I don't think that it helps. I don't think that it matters at all. Medicine-specific research is easier to publish because you can do survey scores, patient satisfaction studies. You can do a lot of things that don't require you to like go to the lab and pipette. And when you're in the lab in the basic science setting, that's very, very important work. But it takes a lot of effort on the front and the back end, especially like molecular research, genetics research, things like that. It's not easy, rat modeling and things like that. It really it's time consuming, and unless you're really, really interested in that, you could start a project and not publish a paper in 2 years, and that may be the window of your application, right? And so if you're when you're talking about improving your chances of getting into medical school, it only makes sense that a medicine specific or clinical research may be a little easier from a means to an end standpoint. But that being said, if you're interested in natural sciences, basic sciences, biology, by all means, I mean that stuff is very, very tedious and challenging, and for good reason, right? You want to make sure that all that stuff is down pat. So Suhas, what is the most fulfilling part of working in vascular surgery? I mean, I love the operating room. So I mean, if I could never have clinic and be in the operating room 12 hours a day, I'd probably like my life even more. And so I just love being in the operating room. So you really the most fulfilling part of vascular specific is that it's nice in that you deal with the part of the technical part of surgery where you get called if a lot of things go wrong. You get called in a lot of acute situations. You get called by other surgeons who run into problems with bleeding. That's being able to help in that setting with complex stuff. It's just really fulfilling. That's probably the most fulfilling, is just being in the operating room, getting results, right? I mean, when you think of medicine as a whole, like surgery is kind of special in that you see the fruits of your labor very quickly. If someone has a problem and you do a bypass, and then they don't have that problem anymore in a few weeks, and it's nice to see that. That being said, there's when you have someone who has a problem because they're smoking, and then you do a bypass and they still smoke, and that's one of the least favorite parts. And so there's pluses and minuses to a lot of it, but a lot of it is just it's almost instant gratification in ways, because you're able to fix something fairly quickly. And just like appendicitis, I mean, you go and you do an appendectomy, and the patient is healed, they're cured of their appendicitis. And so from a surgery standpoint, that's one thing. From a vascular surgery standpoint, I think the technical demands of the specialty here are really what interests me. The other part is what I haven't mentioned yet is the wire, the catheter, the stenting, the ballooning. All of that work that we do as vascular surgeons is is really neat, right? It's so technology driven, putting these, stents that have multiple different branches and all these different arteries. And that part is very technology driven. A lot of imaging, a lot of planning. There's still cases that I do many times where I read the night before about, how other people do it across the country, and and modeling and looking at the CT scan and seeing what my operative plan is, and that stuff is really cool, because you have a plan, you carry out the plan either well or not, and then you take what you learned and put it in the next plan. And that, in my mind, is priceless. Everybody does that, right? I mean, if you're an internal medicine doctor and you gave someone a beta blocker and they reacted a certain way because they had X comorbidity, and then you're going to take that information, and that's what you call the art of medicine. And the same thing with the art of surgery. And so that I got to tell you, that part is probably the best, right? Because I did a case today that I haven't done in a while, and I have no problems admitting I opened the books yesterday and I was reading, and refreshing all the anatomy, looking at the CT scan. I mean, that's our job, right? That's what every patient would want of their specialist, that they're doing their homework and they're on top of it. Otherwise, you run into problems. Let's see, would you be able to cover one of your cases and how you came up your diagnosis driven by? Okay. So I wish I could. I wish I could pull up a CT scan here. I may be able to. Do we have some time? So I don't know if I can mirror this image, but I'll tell you, there's a patient that I operated on today that had a prior bypass in his abdominal aorta, which is the big blood vessel that comes off of the heart, and it gives off a bunch of branches. And after it passes the diaphragm, which separates your chest from your abdomen, it gives off branches that go to the kidneys, the intestines, and then it breaks off, and it goes around the belly button, and it goes to each leg. So this gentleman had everything blocked off from below the kidney arteries. He had a prior bypass. That wasn't an option. And he had an amputation on one side for this problem. And I think this kind of illustrates a lot of what we were talking about. He's still smoking, unfortunately, but he came in with this really bad pain in one leg, and the wound on his amputation side isn't healing. And so you're forced to do an operation that we do, but it's just not that commonly done, but it's done. I did it earlier today. I did an extra anatomic bypass, which is a bypass from the axillary artery right here under the collarbone. Basically goes underneath all the way down through the subcutaneous tissue underneath the skin. And then you basically route the blood from here all the way to each groin to feed the legs blood. And so this is, for example, this one is it's probably been a few months since I did this operation. So I opened up the books and looked up, opened all my anatomy books. And remember, these are the same anatomy books and everything that I trained with, right? So I have my own highlights and I have my own notes of everything that I've done over the years. And after I did the case today, there was a few other perks that I think that I took away from a technical standpoint, and I write those down too, right? And so coming up with a treatment plan in vascular surgery is very different than something else, right? Because you can stent it, you can balloon it, you can use like this roto-rooter type device to clean out the vessel. You can bypass it. There's so many things you can do. And so when you ask me about how you come up with your treatment plan, that's a great question, because that's part of what makes vascular surgery so unique, in that, there's just so many different ways of doing things. And we often joke that if you ask 7 vascular surgeons how to do something, you're going to get 10 answers. You will get 10 answers. That's just, that's, I guess maybe it's kind of like COVID, where like everybody has an opinion because nobody knows. But we justify our answers. You do research based on that, which is part of what we do with University of Houston now. We're all we have a clinical assistant or bioprofessor positions, and we're involved in research to that effect. You spoke about standing out in order to be more competitive to admissions committees. What are some ways an applicant stand out? What are some ways that made your application stand out when you applied? Are you, Vish, are you talking about the medical school or residency? I assume medical school.
Probably medical school.
Okay, so you know, I mean, ultimately, medical still comes down to an MCAT GPA and letters of recommendation game. I mean, you know, I wish there was a better way to put it. I think your exposure to different people and different research options and stuff like that is just limited. And so, you know, put some time into your personal statement. That's important. You know, I'm not saying that make or breaks it, but it definitely helps. You know, you go one way or the other. I think that it definitely helps. Particularly when it's between two applicants, you know, that may be something that helps. You know, the standing out as an applicant isn't there's really there's no set way to do it. But if you want to be subtle, but at the same time you want to be there. You know, we come across a lot of folks who are very aggressive, and I appreciate that because, you know, it really tells me that's what they want to do, right? But then, you know, sometimes, you know, when someone is trying to sell you real estate real hard, you wonder if it's any good real estate, you know. So, you know, so you want to be there, but you want to be subtle in how you're standing out. Sending emails weekly is perhaps not the best thing, and things like that. But when I applied, particularly, I had a very unorthodox background from an academic standpoint, so I think that stood out. And you know, everybody's going to have everybody's going to have their inherent biases about where you went to school, and if you're an Aggie or a Longhorn, and, you know, I'd like to think none of that stuff matters, but and I don't think it does. But wherever you go to school, if you just take the time to get involved in things like this, I think that is what's important, right? Because, you know, ultimately, you have interviews, right? I mean, I don't know if they do them, but, you know, we have at least phone interviews, and then how you carry yourself in that interview and what you discuss, some of it can really make an impact. How do we approach a physician about shadowing concerning the current social limitations? That's a great question. I wish I had an answer. I don't know. The one thing I can say is, you know, take your vaccine and maybe we can, you know, start coming to the hospital again. It's a real challenge. It's a real challenge. I guess this is the kind of forum where that helps. It's challenging. What kind of questions should you ask, or what should you keep an eye out for during shadowing? So I assume this is while you're shadowing. So, you know, the purpose of shadowing, I'll tell you, is networking and really deciding on whether you want to do medicine. Every time I met someone, even when I was a medical student, I would always ask them, you know, a lot of the questions you guys are asking. What is the worst thing about this? If you were to do it again, would you do it? It was actually surprising to me, the number of people that would say, no, I wouldn't do it. And I still ask occasionally, I'll ask folks, hey, if you had to go into medicine again, would you? And you'll be surprised how many people say, no, I don't want to go into medicine. And so if you just ask these folks, you know, these very point blank questions, you know, most folks will tell you, right? And they'll tell you and if so, why not? Just, you know, put that in your bag of further questions or things that it's worth investigating, because you know, in this changing face of medicine, you know, a lot of what drove people to become physicians, you know, may not be true, right? I mean, you know, physicians are not the people that are, you know, making all the money anymore, right? And so if that is a driving impetus, then perhaps you may not, you may be disappointed. Apologies if this was already answered, but what are the but other P's vascular question? What is the path to become a P's vascular surgeon? So there's not, there's just not as much. A lot of specialties are defined by the need for that specialty. So, for example, there's a bariatric surgeon because there's many obese people. There's just not that many vascular surgeons who specialize in pediatrics because it's a older folks problem. It's a problem of multiple comorbidities, which you don't see in the realm of pediatrics. And so, no, there's not. But that being said, the pediatric surgeons do all this. They do all this complex vascular work as well in kids. So there's no specific fellowship for that. But if that's an interest of yours, you would also have to like pediatric general surgery because it's all sort of all encompassing. If you put your shingle up and say you're a pediatric vascular surgeon, you may not have very many patients because there's not very many problems. What type of non-invasive procedures do you perform and what machines do you use for these procedures? Let's see. So we have a fairly robust vascular lab, which does ultrasonography. And we spend a lot of time doing non-invasive ultrasounds, pressure studies. When I say pressure studies, I mean, we do pressures on all across the limb and, kind of look for where there's blockages, how the pressures have changed. And ultrasounds are everything. We do ultrasounds of the aorta and the abdomen, of all the extremities, the carotid vessels. And so, and these are, the predominantly, and, we get very facile with ultrasonography. Even when my wife was pregnant, I was doing the ultrasounds to see the baby. So you get pretty good at it. I wasn't that good, but you get decent at it. And from the vascular world, you'll get very good at sort of analyzing these images and seeing what you need to. But I think that's probably the only real non-invasive. Now, we do a lot of wire catheter-based work, and that's it's kind of minimally invasive. You go in with a little hole in the artery and you put in stents and balloons and things like that. That we do a lot of, and that's actually a lot of vascular surgery. And as technology has progressed, we do a lot of that. We don't do very much. We don't do 100% open surgery the way we used to. When vascular surgery was first born a number of years ago, that was before all these advanced X-ray technologies and doing all these other minimally invasive things. So, from a non-invasive standpoint, a lot of it is vascular lab. What I'm talking about is ultrasonography and dynamic testing. And minimally invasive is a lot of angiography, which is kind of like you guys have, I'm sure, heard of a coronary angiogram where you go up and look at pictures of the heart. And this is similar, but you just go in and look at your desired vessel and treat it. Your stories about Texas rates and overall realness about your specialty really remind me of overarching theme in the book, When Breath Becomes Air, Informing Life and Well Dying. Yes, it's a great book. I read that book. It's been a few years, but it's a fantastic book. Highly recommend it. What personality traits are important for being successful as a vascular surgeon? So I think that it takes you really got to be able to bounce back. The acuity of what we deal with is such that it takes a lot of time and energy that you put in, and a lot of when I say energy, I mean emotional energy, put into a patient and their upbringing, as in through the entire process of the day you meet them to the day where you bring them out of the hospital and say, okay, we're done with your operation, you're doing well. Things don't always go as planned. The ability to bounce back from that is really important from a personality standpoint. And you'll hear this all the time. You want to be able to be the best person you can be. I guess that's the one thing I want to say is that you want to be, I'm a firm believer that quality is always found. Okay, if you are doing good by your patients, by your practice, by your career, by your seniors, you will get to where you're going to go if you want it bad enough. It will happen. That's kind of one of those things that you really need, regardless of what specialty you're going to choose. But as a vascular surgeon specifically, I'd probably say that's the biggest thing. Also, you have to be really hardworking. We work really hard. You get called any hour of the night, and you have to be willing to go. Like, that kind of stuff has to be exhilarating for you. If it's not, then it's going to be work. And I don't know. Whenever I think of my job as work, it really feels like work. And so you want to kind of pick something that will match your and give you that continued zest. What do you see as a rising specialty in the next 5 years? Great question. I think medicine is going through so much change. What things are changing with a lot of ancillary staff too, right? Nurse practitioners, physician assistants, CRNAs, those are all great fields. And I think that the physician extender role is going to really rise in the next 5 years. And it already has. We're seeing it. And so as a specialty, and then there's certain things that are going to become automated, right? I mean, perhaps we'll have an easier way to read images, and radiologists, we may not need as many radiologists. I mean, but this is all hearsay. I mean, I can't tell you for sure. But if you think about the things that technology is helping and the technology is hurting, and if you sort of base it on that, I think if you look at technology and you look at finances and you look at each specialty and how they get affected, you'll probably get a pretty good idea of which ones are going up and which ones are going down. Typical day as a vascular surgeon, I start my day about, I get to the hospital at 7:00. We have my first case at 7:30. And, we like early cases. The OR is an early person's game. So if you really like to sleep late, maybe surgery is not, I'm not saying it's not for you, but you'll get used to it when you guys rotate through surgery and medical school. You're going to be getting to the hospital at 4:30 in the morning. I mean, it's early. It's early, and for good reason. I think you want to get on with the day, and so I'm usually in the OR at 7:30. I have my clinic days and I have my operating room days, and so my clinic days I see patients in clinic all day unless there's an emergency I have to be available for, and then you have to cancel clinic, right? And so that's kind of the name of the game, but. But when you're operating room, you're in surgery all day, and then sometimes you have to go to multiple hospitals. You may be asked to see someone as an inpatient who's admitted to the hospital, and so. But I'm in the course of seeing these folks and doing all this administrative work, paperwork and charts and et cetera, and then ultimately going to. And then going home, I mean, I easily spend 12 to 14 hours a day working, and that's I'd probably say that 12 hours a day is probably average for a vascular surgeon, if not more. You talk about when you were sure you wanted to be and capable to be in vascular surgery during undergrad, DO, residency. You said on my surgery. Did you set your mind on surgery from the beginning, or was it something that you wanted to develop? I wanted to do surgery, bar none. It was I went into medical school to be a surgeon. So the vascular thing, the 4 years that you spend in medical school are the biggest challenge, because you got to figure out where you want to be ultimately, right? What type of specialty you want to do, right? If you want to be a urologist, you got to pick early. If you want to be but at the same time, if you want to be a neonatologist, then you can do your pediatrics residency, and then you still have a couple of years to decide whether you like neonatology or you like, a general pediatrics, for example, or pediatric GI. And so the fork in the road, number one fork in the road is surgical or non-surgical. The next fork in the road is what specialty within that, right? So if you want to be a neurosurgeon or a urologist or a vascular surgeon, or those are different ways to do it, right? And then there's also different paths to each residency, right? So urology is a 5-year residency right out of medical school. Vascular surgery, now there's more and more programs that are 5 years straight out of medical school also. That decision of where you go is it's hard to make that decision. When you're in medical school, it's a challenge, and I'm sure you guys will experience that. And so when you decide ultimately that you want to go into beside the general surgery, and after general surgery, you do a 2-year fellowship in vascular surgery. So part of me picking general surgery, even though I was kind of interested in vascular, is basically allowing me to kick the can down the road, and I can make that decision when I get there, which is what I did. Because otherwise, the last thing I wanted to do was make a decision on doing vascular surgery when I just wasn't set on it. And that's, part of the challenge. And when I was in medical school, all along, it was always just, okay, I want to be a surgeon. And then residency, it was like, well, I'm doing general surgery. I like plastics. I like bariatrics. I like colorectal surgery. I like oncology. I mean, you like all the stuff. And then you're rotating through just like you are in medical school, and you finally realize what you like and what you don't like. And that's when things like technical abilities, lifestyle, all these other possibilities that are there. Perhaps you want to do critical care, for example. I mean, if you like the medical part of the surgical care more, then and all the critical bedside care coupled with the operative care, critical care medicine is a great choice. And so all of these things will start to make sense once you're in this general surgery program, because you have time. That's it sort of worked out for me because I was in a general surgery residency. What made you pick between surgical and the more medicine side of patient care? I think I like working with my hands. It's been like that ever since I can remember. I do classical Indian rhythm, and I do all kinds of stuff. So I like working with my hands. So that was always I still do woodwork and carpentry and stuff like that. I mean, it's just something I've always liked. So and so it was kind of natural. And then vascular surgery is really fine. You're sewing with sutures, the diameter of your hair, and you're doing the stuff like that. And that's the technical part of it is really cool, the microscopic work. And so that's kind of what drove surgery. And I don't want to discount that there's still a lot of medical knowledge that you need when you do surgery. You're just not doing it on a day-to-day basis, right? So for example, like if someone comes in with a stroke, like I have to be able to tell when it's a hypertensive stroke or it's an embolic stroke. And for that, I need to understand, the cornerstones of hypertension and how it works and all these other nuances. But I just don't do it on a daily basis, right? So I don't see folks in my office and change their hypertension medications. But that being said, picking between one and the other doesn't necessarily close doors, right? I mean, critical care medicine is a lot of quote internal medicine, right? I mean, you have to understand all the management of electrolyte disorders and acid-base disorders, and these are all part of the game. And so I think that that kind of stuff, you can definitely create your own niche of what you like, but you'll have to ask yourself, what do you like more, and where would you rather be? And and for me, I'd rather be in the operating room, and then seeing patients and helping them in this acute setting, hence surgery and vascular surgery. Would you be willing to share your email for future questions? Yeah, sure, absolutely. Yeah, if you don't mind, Suhas, just sharing my email address. Yeah.
Yes, you want me to share your HCA email, or do you have a
Yeah, no, you can just give me an HCA email. It's fine. Yeah.
Okay, sounds good. Thank you so much for speaking today, Dr. Desai. It's kind of interesting. Vascular surgery, not many out there, so thank you for taking time and speaking on your busy day.
So absolutely. Hold on. What rhythm style have you studied? Yeah, I did tabla and dolak. I also did Bengali coal. So, but yeah, you guys are welcome to reach out. I think, you know, at your level, you just want to be the best student, the best applicant you can be, and trust me, when that will definitely shine. It's amazing to me how when someone is trying to sell us an application that we may or may not agree with entirely, it's obvious. And so that kind of stuff shines pretty well. And so to what you can do, and remember one thing is that this is your career, you're going to spend a lot of time doing. And so try to stay away from all the naysayers and focus on like sort of purity of your own thought, because that's all you have is your own passion and where you want to go with it.
Thank you so much for speaking. I sent your email in the chat so anyone wants
absolutely
to right there. The link to our stuff there too. Thank you so much.
Sure thing. Good luck to you all.
Thank you.